I'm sorry that I couldn't join you for the whole session. And in fact, I almost forgot that I have presentation. I thought it was tonight. So it was great to be reminded to be here. Here is my disclosure of interest. I've been here for a long time, so I've been speaking to a lot of people, as you can see from this disclosure. The aim of diabetes treatment, of course, initially is to eliminate symptoms when patients present with symptoms, such as polyuria and polydipsia and weight loss. But in either case, whether they are symptomatic or asymptomatic, the most important aim of diabetes treatment is to prevent or at least slow the development of complications, whether it be microvascular complications or macrovascular complications. As we all know, microvascular complications are responsible for the great majority of morbidity in diabetes, while the macrovascular complications is responsible mainly for the mortality of those patients. I would like to start with this diagram to say that we really should look at diabetics in a holistic manner, really addressing all the major important factors such as lipid lowering, blood pressure control, clot prevention, and glucose control. In this talk, I'm not going to address any of the first three on the left. I'm only going to concentrate on glucose control. It's important to see what happens to diabetes treatment and control throughout the years, and this is an important paper that was published very recently from the US in-hand study. And what it shows over the years is glycemic control, and as you can see, it did improve, but it really hasn't gone much. In fact, if anything, it's slightly coming down again. And something like 50% now or less achieve targets of glycated hemoglobin A1C of less than 7%. If you set your glycemic target less than 8, then that percentage goes to 75%. This is in the US. And here they use glucose lowering medication. And as you can see, if we go through some of them, for example, DPP-4 medication has gone up over the years from their introduction to the market in 2006 to about 60%, while sulfonylurea has come down to about 25%. Insulin has more or less gone up a little bit, but again, 25%. But the newer medications such as SGLT2 inhibitor or GLP-1 agonist hover around 7%. TZD, of course, have gone out of favor because of their complications. Now, whether this has anything to do with glycemic control is very difficult to tell. There are other parameters also mentioned in that paper, such as blood pressure control and lipid control. And as you can see, they're not doing much better than glycemic control, considering it's much easier to achieve lipid and blood pressure control. And if you put all those factors in one graph, only a quarter of the patients achieve all those targets in glycemic, blood pressure, and cholesterol control. What's it like closer home? This is a paper in 2018. And if you look at A1C of less than 7%, in fact, barely a quarter, well, it is about a quarter of patients achieve that target. So we're not doing not doing very well here at all. And again, why is that? Well, there are a number of factors such as the nature of disease, limitation of the therapies that we have, hypoglycemia, especially when the patients have long-standing diabetes and need to go on to insulin, tolerability, side effects, cost. The newer medication are obviously more expensive. Compliance to lifestyle and medications is a major risk factors for that. Patients' fatigue, patients' fear, and definitely inertia. Well, leave this sort of thing till 3 months, till 6 months, and both the patient and the physician really complicit in that inertia. So we all know that beta cell function deterioration occurs well before the development of type 2 diabetes, and that deterioration of beta cell function continue to decline despite all our medication. This is from the UKPDS. And you can see the hemoglobin A1C over years, it goes up. At that, of course, treatment here, they only have 3 types of medications: sulfonylurea, metformin, and insulin. Here is durability of medication, oral hypoglycemic, and this is an adopted study from 2004. And as you can see that basically when patients fail, the first medication to fail is actually sulfonylurea, followed by metformin, followed by rosiglitazone. And this is typical graph that you can see with more or less every medication. As you can see, the A1C comes very nicely at the beginning with sulfonylurea, but then goes up. Metformin doesn't do as badly, and TZD, which are out of favor now, does the best. In fact, out of the 3 medications, TZDs are the most durable. It hardly changes over 5 years. And here is a graph that shows that sulfonylurea fails after 33 months as monotherapy, metformin after 45 months, and rosiglitazone after 55 months. So, and here failure is basically defined as A1C more than 7%. Again, those medications such as TZDs and sulfonylurea leads to weight gain, while metformin lead to either weight neutral or weight loss. Once the patients lose a significant amount of beta cell function, then you need to put insulin on board. And in those landmark studies where they looked at patients basically whose glycemic control is not bad, less than 8%, and they want to bring it down to less than 7%, about 6.5%, and they use, at least in this study, I called a lot of insulin. About 64% of those patients require insulin. Severe hypoglycemia goes up by about 3 times. So every time you bring your A1C down, their hypoglycemia rate goes up. This is true, of course, of insulin and sulfonylurea. Similarly, in type 1 diabetes, and this is from the DCCT trial in 1993, when you bring your A1C down from 10 to 7, your incidence of hypoglycemia goes up by about 3 times. And not surprising that a lot of patients say, I'm fine, but I don't have hypoglycemia. Well, a lot of the times their A1C is usually around 9 to 10. And of course, I don't have to tell you that all medications, everything we do in life have side effects, some of them minor, some of them infrequent, some of them big, and some of them more frequent. And as you can see, one of those patients will develop some of those side effects, and they may want to stop it. So if you go to GI and metformin, about 25% of patients do have GI side effects, and some of them don't want to continue. Similarly, 15% of patients will have nausea, severe nausea, secondary to GLP-1 agonists, and some don't want to continue, although the majority do well. The other factor is cost, of course. When we come to the newer medication, their cost goes up. And many of the institutions really limit the use of those medications to certain specialty and certain patients. So there are other ones that we mentioned. I'm not going to go over them, but you can see that that are important in lifestyle, compliance, and inertia is important here. Well, here is the medications in 1993 when I finished my fellowship. That's an important year for me, of course. And here are the medications now. In fact, you have so many combinations even that it will fill up this slide. And therefore, we need to know, which one we should use, what is the efficacy, what is the cost, what is side effects. And it really is becoming very difficult for the, general practitioners and even other specialties to know what these medications are. These medications really address many of the pathophysiological defects in type 2 diabetes. So we have, for example, incretins that address the incretin effect. We have the increased glucagon secretion. Again, incretin does decrease glucagon secretion. And we have the insulin sensitizers and so on. And we have SGT inhibitors that, of course, decrease glucose reabsorption. So here is the usual standard way of addressing type 2 diabetes. We start with lifestyle, sometimes a combination with metformin, and we gradually go to dual, triple, and sometimes quadruple therapies. And we go to basal insulin and basal bolus. Of course, this paradigm has changed with the advent of GLP-1 agonists. And in fact, what we do here is we prefer GLP-1 agonists before insulin therapy. And how do we choose our diabetic medication is according to those parameters: efficacy, safety, their effect on weight, side effect, cost, durability, and so on. And before going to talk about efficacy, I'd like to mention this phenomena that many of us are not aware of, that the efficacy of any medication is dependent on the baseline hemoglobin A1C. So if you have a medication and you want to try it in a patient who have A1C of 7.4, then they're not going to do that well because you're not too far. However, if the baseline A1C is about 10, then their efficacy will be extremely good. This one basically illustrates, for example, this is an dulaglutide and liraglutide. As you can see, the higher the baseline A1C, the lower the decrease in A1C. So if your A1C is 10, you can expect the A1C drop to be about 2%, 2 plus. If your A1C is 7.5, you barely reach 1 percentage point. So when you want to compare A1C reduction in those medications, you really need to look at what their baseline hemoglobin A1C is. And again, this is another phenomena. And here we look at, for example, sitagliptin and metformin. So this is sitagliptin and this is metformin, 2 grams. And as you can see, when the A1C is low, you don't really drop your A1C much. But when the A1C is high, look how much you drop A1C by 1.6%. That's in sitagliptin, and by almost 2 percentage point with metformin. So look at the baseline A1C in any of the trial that you see with whatever anti-diabetic medication. So let's go back a little bit in time. This is 2003, and this study compared pioglitazone metformin in patients with baseline A1C of 8.6. As you can see, by the end of 32 weeks, they're hardly any different. There is a reduction of 1.3 percentage point. Here's empagliflozin efficacy, and this is placebo subtracted. So it doesn't give you the full picture and the other, but it does tell you that the A1C of hemoglobin of empagliflozin is around 0.6, 0.7% reduction. Look at the baseline hemoglobin A1C. For the most part, it's less than 8. But if you put patients with hemoglobin A1C of 9, you're going to see this well beyond 1 percentage point. Here is dapagliflozin. Again, this is not placebo subtracted. So this is placebo. If you subtract from here, it will be the same as the other one, about 0.6, 0.7% reduction. Again, look at the baseline hemoglobin A1C, about 8%. Look at this one instead. When the baseline hemoglobin A1C more than 9%, you do drop your A1C by 1.5 percentage point approximately. Now, here is dulaglutide. And there are 2 phenomena here. Number one, the baseline hemoglobin A1C is 8.1%. And I want you to look at the comparators here. So if you look at the higher dose of dulaglutide, which is 1.5 milligram, you're really looking at reduction of almost 1.5 percentage point. This cannot be achieved with any of the oral hypoglycemic when your A1C of 8.1. Here's sitagliptin. So you're almost achieving 3 times as much with injectable therapy as with oral. If you look at the glargine, this is something we do in the past all the time. Again, 0.6% glargine versus 1 point something percent with dulaglutide. This is both basal bolus, so glargine and lispro, and again, it cannot compete with dulaglutide 1.5%. So here again, GLP-1 agonists have really changed the field and the way we treat diabetes. Again, if you look at A1C, people achieving A1C less than 7%, dulaglutide have a higher dose achieve better A1C reduction than all of the competitors combined. That's important. Also is weight reduction. Some of the medication does lead to weight gain, such as sulfonylurea, insulin, and TZD specifically, but not the others. Here, GLP-1 gives you additional important effect, which is weight reduction. And here you're talking about 3 kg weight reduction compared to 2 kg in basal bolus and or 1.4 kg in basal therapy. Semaglutide is another GLP-1 agonist, and again, this is a sustained program. And again, what I'd like to point out is the fact that baseline A1C in those patients about just over 8. Look at the comparator. So if you look at sitagliptin here, sitagliptin only achieves 0.5 percentage point reduction. Look at the higher dose of semaglutide, minus 1.6, nearly 3 times. Again, you're looking at, for example, glargine, basal insulin, minus 0.8 versus minus 1.6. So GLP-1 receptor agonist really beats insulin, basal, as well as oral hypoglycemics. Again, looking at the weight here, you're looking at a reduction of between 4 and 6 percentage points. Now, of course, most patients will need insulin throughout their lifetime, whether inpatients or outpatient, due to basically loss of beta cells. And we have a number of ways of addressing this. Basal insulin analogs, basal insulin, for example, premixed, twice a day, prandial, or a combination of basal and prandial. Each one has its advantages, and depending on your patients, you may want to choose one or the other of those medications. It is important to mention that when your hemoglobin A1C is in the lower side, such as less than 7.3, it is the postprandial that really contributes more to A1C. However, when your A1C is high, such as M5, it is the basically fasting of blood sugar that contributes more to A1C reduction. So how do we choose? Well, this is a very important landmark study in 2007, which compared biphasic insulin, prandial insulin, and basal insulin. And if you look at glycated hemoglobin A1C, you see that biphasic insulin and prandial achieve the most. Basal insulin does very well, but not as good as the other. On the other hand, if you look at fasting plasma glucose, it is the basal insulin that does best, followed by biphasic, which is premixed, followed by prandial. If you look at the postprandial, the picture, of course, favors the prandial insulin, followed by biphasic, followed by basal insulin. If you look at body weight, the best that doesn't really increase that much weight is basal, followed by prandial, followed by basic. Again, everything has a price. Hypoglycemia is lowest with basal, highest with prandial, and not surprising, because here the patients need to know how to balance carbohydrate with prandial, with the dose of prandial insulin, followed by, of course, biphasic. Now, here is a premixed 25 glargine plus lispro, and as you can see here, that premixed does just as well as basal bolus regimen. So really, if you choose your patients right, You can choose either basal bolus or premix, depending on their basically what they'd like to do and their lifestyle and their food and so on. Again, a very important point these days is that you don't have to be adjusting the insulin yourself. You can ask the patient to do the adjustment. And here, a study to look at self-managed versus physician-managed adjustment in basal therapy. And here, looking at, I believe it's Tokyo, where you look at both, and you can see that self-management. So if you tell the patient to adjust their insulin, does even better than physician-managed adjustment in insulin. Here is hemoglobin A1C reduction, and here is fasting blood glucose. So if you basically educate your patient well, they will be able to actually reach that milestone. Now, this not only applies for basal, but it also applies for prandial. And here is a study that looked at physician versus patient-driven approaches to insulin-prone type 2 diabetes. And again, without having to go through details of this, I'm running out of time. You can see that if you educate your patients well, you can achieve your target by letting the patient adjust their insulin. And again, you see here the 8-point finger glucose monitor, and you can see that it is the same in both. Very important points to consider nowadays in type 2 diabetes, cardiovascular and renal consideration. You're aware that the FDA mandated cardiovascular outcome trials in 2008 of all new medications. And since then, close to 200,000 patients have been enrolled in those outcome trials. As you can see in DPP-4 inhibitors, shows that they are very safe as far as MACE cardiovascular side effects. And when you look at GLP-1 receptor agonists, they showed really not only they are safe, but they actually show superiority. So the first study to come out to show positivity is liraglutide with reduction in MACE, major adverse cardiovascular events, and that's basically cardiovascular death, not fatal MI and stroke. Sustain is the semaglutide, again shows a reduction in primary outcome, a reduction in stroke. This is a mainly non-inferiority study. Albiglutide, no longer in the market, again was positive for primary outcome and significant reduction in MI. And dulaglutide, again, it shows reduction in primary outcome. Very important in dulaglutide, which is REWIND, is that this is the only study that shows a reduction in patients not only with established cardiovascular disease, but in patients with high risk factors. So patients who did not have established cardiovascular disease, something we call primary prevention. So dulaglutide is the only one that really gives you primary prevention results. When it comes to SGLT2 inhibitors, you are very aware there are so many studies there, and the most important ones are actually listed here, either in diabetes with cardiovascular disease, and there are heart failure studies, and we just heard about the Emperor Preserved only yesterday, and there is also kidney-directed therapies. So if I'd like to summarize the SGLT2 inhibitors, you can see that only 2 studies have achieved primary endpoint for reduction 3 MACE. That's EMPA, which is EMPA-REG, and Canvas study. All of them actually reduced heart failure all of them. However, as I say, only those 2 have achieved their primary outcome. A dedicated heart failure study. How many?
2 minutes. 2 minutes.
2 minutes. I'll be finishing literally in 2 minutes. So if you look at dedicated heart failure studies, there's a DAPA heart failure, and this is the one that shows reduction in cardiovascular death and of course mortality, heart failure. and Emperor shows reduction in heart failure and heart failure or cardiovascular death. If you look at the kidneys here, Credence shows both 3P MACE reduction, cardiovascular death, and heart failure reduction, while DAPA-CKD shows that there was a reduction in all-cause mortality. All of those studies shows whether they are as a secondary outcome, shows a reduction in kidney outcomes. And here are the most important one. This is basically canvas. You can see that there's a reduction in all kidney hard endpoints. Whether it be a cardiovascular death, renal replacement therapy. Here is a DAPA-CKD, again, significant reduction in major hard endpoints here, such as end-stage renal disease and cardiovascular death. So that, of course, led change in guidelines. And as you can see in the left side, very important after metformin to really look at your patient as do they have established cardiovascular disease, heart failure, chronic kidney disease, or they don't. If they do, then you really go to this and you use basically medication that have proven cardiovascular protection. And so if they have atherosclerotic cardiovascular disease, you go to the GLP-1 receptor agonist. If they have heart failure or chronic kidney disease, you go to SGLT2 inhibitors. On the other hand, if they don't, you can choose whatever you want, depending on whether you don't want hypoglycemia, then obviously SGLT2 and GLP-1 receptor agonist, DPP-4 inhibitor, TZDs. If the cause is a major issue, then you go for sulfonylurea and TZDs. If you want to reduce weight, then you go for GLP-1 receptor or SGLT2 inhibitors. Once you fail with the oral hypoglycemic, you should really consider going to GLP-1 receptor agonist before you go to insulin. And the first choice of insulin would be basal insulin. Once basal insulin really fails, then you can either add one bolus or two boluses, or you can actually use a premixed insulin, especially in those patients who really cannot do not want multiple daily injection. With that, I thank you for your attention and hope that you have a nice week.